Welcome to the village. It's National Antibiotic Awareness Week, so I thought it would be a good idea to talk to Gabe Sasso. He's a clinical pharmacy specialist here at St. Mary's, here to talk to us today about why that's important and what that means. Hi, Gabe. Thanks for being with us.
Yeah, thanks for having me.
Yeah. I'll let you, introduce a little bit more about what that means, what you do, and especially you work with all the providers in many facets of the hospital, but you are part of the antibiotic stewardship program.
So I am the clinical pharmacy specialist here at St. Mary's Hospital. I'm also a board certified pharmacotherapy specialist. One of my main roles at the hospital is I lead the antimicrobial stewardship team. We work very closely with providers, working on, really looking at what is the most appropriate way to utilize our precious antibiotics, our antifungals, antivirals, and working through that every day is really looking at our patients, looking at their cultures, their allergies, what are we using them for, and that's essentially the day-to-day. And why it's so important is we really want to use the antibiotics the most optimal way possible. And we also want to reduce the side effects that patients can have, the adverse outcomes patients can have. Because I think we always think of antibiotics as positive things, like we're going to treat what we're treating. But there is things like C. diff that can happen with antibiotics. So I think it's very important to always use only what's necessary and not overly use them to the point where you can see those bad outcomes.
The creation of antibiotics was so dramatic in how much it improved medicine and our ability to take care of people, and so life-saving. It's hard to even gauge how many lives have been saved. I mean, if you think about it, antibiotics treat bacterial infections. Bacterial infections such as urinary tract, pneumonia, all things that can lead to sepsis. And if we don't have antibiotics that work within hours to save lives, people would die of simple things like a urinary tract infection. Scary to think about, right?
It is. They're absolutely life-saving, and preserving their effectiveness, I think, is just crucial. And that's why antibiotic stewardship is just so important.
We looked up right before we started recording, a fun fact of, you can tell everyone how antibiotics came to be, right?
Yeah, so we just found, I knew that penicillin was discovered by Alexander Fleming, but interesting fact is that it was actually discovered at St. Mary's Hospital in London in 1928. So small world, I suppose.
Small world. Not too long. That's less than, how many years ago was that? It's 2022.
Just under 100 years.
Yeah, and we've used the heck out of them, right?
Absolutely.
Now we're finding a problem. So I think many people don't realize how much of a problem it can be to not use them efficiently, because using anything, too much of a good thing is not good, right? So what is the problem? What are we seeing now?
So now we're seeing a lot more challenging infections. We're seeing organisms that are resistant to some of the drugs that used to be effective. So one example is, people probably commonly hear the thing called MRSA. Well, MRSA by definition or by name is methicillin-resistant Staphylococcus aureus. Yeah. There is something called methicillin-sensitive Staphylococcus aureus. So some just happen to develop resistance to some of the, how we call them, less broad spectrum drugs. Like your common things you might see, like Keflex, which is used often in outpatient settings. But when you start to develop resistance, you start using more potent, stronger antibiotics that often come with more toxicity. Yeah. So ideally, we want to use the less broad spectrum drugs so that hopefully resistance doesn't, progress, and kind of keep patients safer in that aspect and more tolerable of the drugs that we're giving them.
And it makes sense, right? Because if you think about it, these bacteria, any of these, we call them microorganisms. Bacteria, viruses, fungi, we're all trying to get smarter. We're all trying to improve our genetic code so we survive. So bacteria are going to do that too. So
they do, and they do it very well.
And they do. So they've come up with ways to resist these drugs. They don't want to die either, right? So, and that's why now we have this resistance. And it occurred to me when you were talking about this too, because we get children with MRSA too. This is not just a very sick adult problem. This is a everybody problem. Right.
It is much more commonly we're seeing these things, and unfortunately, I think it's an effort on everybody's part. We do the best that we can to, I think, treat the patients, come up with the best regimens. But I think the best way I can put it is just it is a complete team effort on the part of patients, providers, pharmacists, nurses, everybody involved, because I think educating the public on when antibiotics are appropriate and when maybe they're not necessary is crucial to really combat the resistance that happens, because the more we give these, like you said, these bugs are very smart.
Yeah.
Like they're going to find ways to evade and learn how to not die.
Survive, right, exactly. Survival skills. So I found this on the CDC website. The CDC estimates that 47 million antibiotic courses are prescribed for infections that don't need an antibiotic per year, just in doctor's office and emergency departments per year. And that's 28% of the prescriptions that are prescribed in those locations. So why do we say they didn't need the antibiotic? And why is it that this is happening? Why are antibiotics being prescribed wrongly?
Yeah, that's a great question. Oftentimes I think it can be hard to determine what is bacterial versus not, I think, at times. We often call that empiric therapy in a lot of settings, where you kind of start with something and then you pull it back later if, the information changes.
Yeah.
But often I think these indications where people are getting antibiotics where they really don't need them are your upper respiratory infections, your sinusitis, your acute otitis media, your ear infections, where a watchful waiting or some other strategy is probably going to be more effective and it'll run its course. And I think people oftentimes think that they got better because they got a 5 or 7 day course of antibiotics, but really that was probably the disease just going away at that particular time.
I think the concept of watchful waiting is hard. I think people want to walk out the door feeling like they were given a prescription, that they were given something to make this thing go away.
Yeah.
I think it's a lot of psychology between patients and the providers, because as a provider too, you want to feel like you're doing something too.
Yeah.
It's kind of like a discussion that happens every time. Do we do the antibiotic or not? You don't want to take that chance, or there is a sense of pressure. You can kind of pressure someone into making you think, well, well, in my case, kids, but patients too, I'm sure, like, this has been going on a while. They're not feeling better. And there's a lot of things with children, too, in particular. They're more tired. They're not acting themselves. They're not eating. And then you're wondering, are they getting worse? Like, is this like they're up all night coughing, they have phlegm, they've been sick, and there's a post-viral phenomenon of being tired and fatigued, and they need time to recover. So there's a lot of that, not wanting to do the watchful waiting, or, we're coming on a weekend. What are you going to do over the weekend? If things get worse, then they're going to end up in the urgent care ER, and they're probably going to get the antibiotic there.
You're right.
So it's like, you see something and you want to treat something and you want your kid to get treated. It is psychological. So I think reassuring ourselves as providers, reassuring the parents that you need to do this, this, and this, and give it time, and have like a back and forth. Make them realize too, we're not sending you out the door. We're going to have a conversation in a couple days. We're going to see how they're doing. They're going to come back, or you're going to portal message, or we're going to have a phone conversation. Just kind of keep, like, we're not doing the antibiotic, but I'm holding your hand through this.
Yes.
We're holding each other's hand, because I know you're going to come back and tell me, so I don't have to worry either.
Right.
So I think it's a lot of psychological, this antibiotic prescribing is a lot of psychology.
Yeah. There's data to suggest that those type of strategies where, really good communication, people do feel a lot better about that.
Yeah, just communicating.
Absolutely.
Yeah, it's not always what you say, but how you say it too.
Reassurance, like you said, I think is huge.
Yeah, I feel like I'm kind of talking myself into it more as we're having this conversation. For the sake of feeling better temporarily that we're doing this, look at this huge sacrifice we're making in society. Like, these kind of side effects, like you were saying, it's a major public health problem.
It is.
And it's affecting future generations, right? Because these antibiotics are just getting stronger and stronger, meaning they're having worse side effects.
Oftentimes really the oral drugs that we have, are really, we don't have that many that are available for some of these resistant infections. So the more resistance we see, there's a higher likelihood that patient's going to end up having to go to the hospital and not be able to be treated as easily at home. That's where the challenge comes in as well. And quite honestly, antibiotic development is really not there. I mean, there's just not a lot of antibiotics being developed for some of the more common things. There's a lot of antibiotics in the pipeline being developed for very resistant type infections, but you hope you never even have to use them. But there's no new antibiotics really being developed for your common stuff like UTIs and community-acquired pneumonia. There's some, but certainly not as much as you'll see for other, disease states.
Yeah, and you don't get to use just those simple regimens anymore. And
you're probably not using amoxicillin as often for just pneumonia. I mean,
and if you think about it too, like there's resistance just for walking pneumonia. Like you may not be able to get away with just a Z-Pak like you used to.
Definitely not. I mean, for adults, almost always I feel people end up on 2 drugs.
Your infections are failing. Like there's resistant UTIs for kids that never had an infection. That brings me to like thinking about Levaquin, right? So Levaquin is one of those, the fluoroquinolone, it's one of those drugs that you can use for like a walking pneumonia or a sinusitis, a community-acquired pneumonia, right? Why do we want to avoid something like a Levaquin?
Yeah, so that was something we did a lot of work here at the hospital and really in our outpatient settings throughout the hospital and really reducing our Levaquin use, our ciprofloxacin use, because they have lots of adverse effects. Some of the rarer ones, but they happen is people end up with tendon rupture.
Yeah, that's pretty painful and significant.
Right. The resistance that has occurred with these drugs as well has spiked and probably related to a lot of use. And that kind of probably ties into something we'll probably get into after, which is penicillin allergies and avoiding drugs and using these. So there was a lot of times where people would use Levaquin or Cipro very often because people aren't likely to be allergic to them and they cover lots of different bugs, so it was a little bit easier, but they come with higher risk of C. diff, like I said, the tendon ruptures. So I mean, they have a long list of bad outcomes that can happen or bad adverse effects, and we try to avoid these as much as possible.
It's not just a simple alternative, like A doesn't work, it's plan B. Like, it's not so simple.
It's not so simple.
Like you said, like C. diff, just trying to educate people, right? If you put an antibiotic in your body to kill bacteria that shouldn't be there, it's going to kill bacteria that should be there, and then other bacteria that normally would be kept at bay give you an infection. It's like a whole series of things that happen and can go wrong. It's a bad series
of events, and even C. diff is harder to treat now. So you really see all these ripples from antibiotic use or overuse. So it is definitely a major public health thing. I'm very passionate about it. I think it's a very important topic.
I've heard. I heard you're passionate about it, so you're the right person to talk to. So actually with C. diff too, it can be life-threatening in itself, right?
Absolutely can be life-threatening.
So if you have C. diff, it can cause death. So it's actually part of the statistics I was reading about how antibiotic resistance causes death. Because if you don't have the antibiotic, like you said, you had somebody in the hospital just recently with a pan-resistant bacteria. So you have nothing to treat this person with. Or even if, say, you had people that had like a multi-drug resistant, by the time you find the one, or if you can't easily treat someone with a bad bacteria in a hospital, the statistic is that antibiotic resistance is killing at least 1.27 million people worldwide and associated with nearly 5 million deaths in a single year. In the U.S., more than 2.8 million antimicrobial resistant infections occur each year. So at least 35,000 people die as a result. That's just in the U.S.
Right.
And then you add C. diff to that, and then you have more deaths. And the cost of all, these newer drugs you're talking about,
much more expensive.
Exactly. And hospital costs, it's billions of dollars that are we're talking about like $4 or $5 billion in healthcare costs because of overusing antibiotics. It's insane.
It is.
No wonder why you're passionate about it. This is crazy, right? This is why it's such a big problem, right? Yeah. You're not treating people as much. It's very costly. Side effects,
It leads to longer length of stay.
Yeah.
I mean, patients possibly have to go on long-term antibiotics at home, IV.
Right.
There's lots
Yeah.
of
There's
negative things to be had with this, and that's why it's important to,
yeah.
I think, really, use them as appropriately as we can.
Yeah.
And I'm not saying in any way that we shouldn't use them.
Yeah.
We're using them in, like you said, the best way possible.
Yeah. I think that's the point, because we want to use them, but we want to use them when they're needed.
Correct.
Or else we're not going to have them. It's almost like if you abuse it, you lose it, kind of thing.
That's exactly what it is.
We're not trying to abuse it, but we are. Right?
Yeah, we are.
The problem is not realizing what a big deal it is when you simply give a medicine. It's not just that one person, that one patient, that one time. This is all adding up and creating this. Yeah.
I mean, you had great statistics on the outpatient setting on what the inappropriate antibiotic use is. Hospital setting, it's like upwards of like 50%.
Yeah.
That's amazing. That's a huge statistic.
Yeah. So you're saying we're making some progress towards this with education and awareness and trying to be mindful. And I think some people too in the public are realizing too they don't want to have the side effects. Like even as simple as, well, not so simple, but diarrhea, like just just not feeling good in your stomach. COVID, right? You notice with COVID, it was kind of a few steps back there. How much of a step back did antibiotic stewardship take?
It was I would say there was some significant setbacks nationally with stewardship, and it's been well documented. COVID was a very challenging, it's still challenging, but, we didn't really know a lot about this virus, and the risk of a secondary bacterial infection or a pneumonia on top of it was really unknown initially. And a lot of patients, this is a viral infection. A lot of them got antibiotics. So that becomes worrisome when you're giving a viral infection antibiotics.
Right.
And the statistics slowly start coming out in 2020. I don't remember the exact statistic, but I want to say it was something like 15 to 20% increase in antibiotic use or resistant type infections.
Yeah.
And that's only what we know from that time. So you can imagine that's probably creeping up as well. So I think the most important takeaway from that is taking your eye off the ball. We really lost some progress there. And I think it's important to get back to that and really make sure that we get back to those good things that we were doing so that we can not see that happen.
It is unfortunate that COVID took our eye off a lot of things. Like, it was good we were very COVID focused, but then we were also falling behind on progress. Things like vaccines. Now anti-vax means a whole different thing, right? And the progress with this is so important. Like, I noticed too, because in my mind too, we were doing a lot of telehealth visits. There's also the private telehealth companies. A lot of people use them through their insurance companies. Now, the telemed provider, they don't know the person, and just hearing something, or even during COVID, your own provider, they don't know and they can't see or listen. All those clinical skills are not being used. And so you don't know. You're playing a guessing game.
Right.
And you're prescribing antibiotics a lot more. Over the past 3 years, a lot more.
And I'm sure a lot of that contributed to the statistics that we were seeing.
Yeah. And so we need to get back to the in-person. Like, I think telemed is great for certain things. I think it's great for the busy parent or patient, yourself, a person who's like at work and wants to do like a quick thing. It's great for like the mental health. You don't need to be in person unless you want to be, but it's hard. You can't diagnose an ear infection without looking in an ear. It's hard because we've already overuse with strep. Like, you need that positive strep culture.
Yeah.
A lot of things look like strep that are not strep. The majority of pharyngitis, sore throat, is not strep.
Yeah.
Yeah. So keeping those things in mind. So what else is happening in the hospital? What's your way to educate? What do you do on a daily basis, and what should we continue to do?
Yeah, so on a daily basis, I think the biggest thing is for me in a hospital setting, is really looking at the patients that we have in the hospital. I kind of keep a rounding list of some of my patients that I'm targeting to kind of help the providers out, looking at the cultures, seeing if they're, is there anything growing? If it is, then I start looking a little deeper as to what the regimen is. Can we switch things around, use something less, like I said before, broad or less potent, trying to use just enough that is necessary to treat the patient appropriately without using too much, because like we said, we don't want to have C. diff, we don't want to have adverse effects that obviously the patient doesn't want either.
Right.
That's some of the big stuff. And then really optimizing order sets, looking at what we're doing globally, what is our go-to regimen for community-acquired pneumonia, for UTIs, making sure that we are up to date with the guidelines and ensuring that we're treating people optimally. I think is some of the biggest things that, as in my role, that I look to do for our hospitalized patients.
What else can we do? I mean, educating, reassuring, right? Like we said.
Definitely that. And I think some of the biggest things that I see in hospital that we struggle with too is the penicillin allergies.
Yes, and you want to definitely address that.
I think that's where it becomes difficult to pick a regimen sometimes based off of that. So we really, I try to dig into those patients and see, maybe they've had something else. Like they have a penicillin allergy listed, but maybe if they've been here before, or if I can gather any data, have they ever had a cephalosporin or something similar, so that we can say, okay, well, maybe they're really not allergic. Challenging, but I think that's a great initiative as well for when the patient's back in primary care setting, and maybe allergy testing is another good initiative to see if they truly are allergic, because avoiding these agents that are first line just exposes people to the drugs that we don't want to use, which is like the Levaquins,
right,
things like that.
Yeah.
So
exactly, because penicillin is it was the original, right?
Very tolerated. It's the original.
Right. So
it's really effective when it can be used. So
yeah, it's a good drug, and people do often think that they have a penicillin allergy. Now, why is we have to get to the root of why they think they have it and figure out what happened, because you might have a 50-year-old who their mom told them when they were a baby.
Happens often.
And I see a lot, parents wonder if their kid had an allergy. But when a child has a viral infection, they will oftentimes have this bumpy pink-looking dots on their body from the virus, from the fever breaking, from whatever the case. And actually, many viruses, if you give somebody a penicillin, like amoxicillin, thinking they have a bacteria, but they really have a virus, they will get that reaction. So it's not a penicillin allergy, it's a reaction to giving penicillin the wrong way, right?
Yeah.
Mono is notorious. You give someone amoxicillin, they have mono, they will get a rash.
Yeah.
And it's not the penicillin's fault, right?
Right. Yeah, that's huge, and I can't even state that enough, where if we can understand whether or not they're truly allergic, it really sets them up for success to have a better regimen. Like I said, alternative agents or alternative drugs are not ideal for them. And
it's better for you if you don't have a penicillin allergy.
It is better for you if you don't have a penicillin allergy.
Yeah.
That is very true.
Right. And then they say, there's that cross-reactivity with cephalosporins, but that's a small percentage.
A lot less than we previously thought. One of the things was that penicillins and cephalosporins were kind of manufactured similarly. So historically, there was probably lots of cephalosporin drugs that were actually probably had some penicillin component in them.
Okay.
So that would explain some of maybe the earlier data. But really, less than 10%, maybe even less than that, have a cross-reactivity. So unless you've had, true anaphylaxis to a penicillin, probably in a lot of cases going to do pretty well with a cephalosporin. A lot of pharmacists, providers, we all were taught, at least I was taught initially, that penicillins and cephalosporins were it was based on the family. That's how you determine cross-reactivity. What we found is actually really much more detailed down to what we call them side chains in chemistry and organic chemistry. Like these little pieces coming off of the compound is what determines it. So there's even less cross-reactivity even within the same family. So it's
that's neat.
Interesting and I guess a little nerdy, but when you get down to it, like for example, we use cefazolin a lot for surgery, for pre-op, and that one is unique in and of itself, is different than all the other ones.
That's so cool. I didn't know that. Actually, I majored in chemistry, but that was 2 decades ago, so I forget a lot of the stuff that you knew. But you can nerd it out here. safe space. It's cool. But it is interesting.
Yeah.
These little chemistry pieces, they matter.
Yeah, and I think more of this data is coming out because of the problem that we've seen with penicillin allergies. So I think there's more to come with this, and there's going to be more research out there. But yeah, right now we know a lot of people, they do tolerate some of these drugs quite well.
Well, that's actually a light, too. It's kind of like bringing back some drugs we thought we couldn't use.
Exactly, and that's really what it is.
Yeah.
You say, okay, maybe we can use Caflex in this patient.
So there is hope.
Yeah,
there's
some hope.
Yeah, good. Definitely to keep in mind, too, like an allergy, that little prickly rash is not an allergy. Nausea, vomiting is not an allergy. Diarrhea is not an allergy. That's all stuff you do when you take an antibiotic, which is why we don't want you taking the strong ones, right?
Right.
More like the urticaria, the hives, the big hives.
Big ones, yep.
Like a little bit of swelling, and like you said, the anaphylaxis, which I suck at pronouncing, but I mean, I feel like your throat's closing up or there's swelling happening.
Yeah.
That's a true allergy. That's something you need to be careful, right?
Yeah, and I think, sometimes we see penicillin allergy listed, patient doesn't remember what happened. So I kind of look at it like if they don't remember what happened, it probably wasn't anaphylaxis. Most likely.
Right, exactly.
You're going to remember that.
You would remember the day that you were in the ER not being able to breathe. It's
probably.
Pretty significant day of your life. The other thing I think that people do need to realize or just be educated on is like we're talking about microbes, right? So an antibiotic is a term for the medicine for bacteria.
Correct.
There's different medicines for the different microbes. You have antifungals, antivirals, antiparasitics.
Yeah. The big umbrella is, we call it antimicrobial stewardship, meaning all of them. So there's antibiotics for bacteria, antifungals for fungus, antivirals for viruses. I mean, that's definitely something that I think would probably help to explain to people, and then maybe they would be more receptive to, oh, wait, if this is a virus, then I don't really need a antibiotic.
Right. Because they work so differently. Like you said, the reason why antibiotics work for bacteria is because they work on specific parts of the bacterial body. They work on the wall, on the membrane.
Everyone is designed to target something different.
They target something, exactly. And all the classes target something within that bacteria. Right. So they don't all work the same way within themselves either.
No, and that's why sometimes we combine antibiotics. We might not, number one, know what we're treating initially. Yeah. Or some of them work better together. Right. Synergy. Yeah, right. Which is less common, but that's why we do that. And that's why we use different antibiotics for different conditions, because you're targeting a different organism. Like, you're not going to typically use the same thing for a UTI as you're going to use for pneumonia, because you have a whole different set of organisms that are probably causing the infection.
Right. There's different things in the environment or in your own body that are causing these infections. And they're different little bugs, you can't treat them all the same way. Then they're completely different from viruses. And we all know from COVID, I hope society learned one thing, that viruses like to mutate.
They mutate a lot.
They mutate
and they're very good at it.
That's why it's hard to find a drug to combat these viruses. They mutate way too quickly for us to find a drug. There are specific antivirals, and we're very fortunate and very blessed for like HIV drugs.
Yeah,
it's amazing.
It's a modern miracle.
Yeah.
I mean, there's so many different ones, and the research there and the things that were done for the HIV virus is just phenomenal.
HIV is such a sad and difficult viral infection to have. I feel like as a world, everyone tried to really get together and wanted this to happen. It's amazing.
Yeah, it went from very complex regimens for HIV. Now, we have actually an injectable that people can use.
Okay, so how often do they use that?
That one is monthly.
Okay, cool. So, and they do it once monthly at the doctor's office or at home?
Yeah, at an office. Usually at the doctor's office. I believe they have to go in for it. But, they've come a long way, and there's obviously more that are probably going to be developed. And, it helps with adherence. You don't have to worry about maybe taking an oral therapy, once, twice a day. Yeah. That wouldn't be a perfect regimen for everybody, but there's a lot of evolving things in that field too.
Yeah, it used to be they didn't have anything, and now there was 3-4 medicines a day, horrible side effects.
Yep.
And
the drugs are a lot more tolerable now.
Yeah, but that's a blessing with HIV. But you can't necessarily do it with every single drug. Like you can't do it with every cold virus. There's thousands of them, right?
Yeah.
So what we do have though, which is we have vaccines. Measles, mumps, rubella, polio, chickenpox, hepatitis A, B. There are so many vaccines. It works differently. It's preventative.
Yeah.
So you don't need to get the virus and then not have an antiviral to treat it.
Yep.
This is another technology. Besides antibiotics, this was like another huge step up in medicine that we're also losing.
Yeah, absolutely.
And this is purely, a misunderstanding with the vaccines that we won't get into today. But yeah, that's a prevention because the way the viruses work is you can do vaccine technologies more appropriate for them. Because some viruses that don't maybe evolve as quickly, you can get a good vaccine to help prevent them. Something like the flu does evolve, but you still have some protection with the previous flu vaccines. And the more people are vaccinated, the more, because viruses are such that they like to go body to body, right? Much more easily than bacteria.
Right.
So if we team up against them by all being protected against them, they have nowhere to go. Yep. So that's why the concept with vaccines is a little different. So
it is, yeah.
We kind of have something brewing for everything, right? I mean, your fungi too. You have lots of antifungals.
Lots of antifungals. More of those coming. Those are also becoming more resistant.
Are they?
But they're less common. I mean, they're not as common as your bacteria.
Yes,
more so the patients that are immunocompromised and on chemotherapy, things like that. Those are more likely to be affected by a fungal infection.
You're mainly going to see like some skin fungi.
Yeah.
If you're outpatient or pretty healthy, but those.
Your full, systemic fungal infections are much more rare.
Yeah, and harder to treat, and
they are.
They're tough. Yeah, it's tough because these people, it's really like these sickest of people with the cancers, who are immunocompromised. They're depending on these antibiotics to help treat them. We have to think about it.
They're very at risk, and some people are on things prophylactically while they're going through treatment. So very important for going back to using things appropriately.
Yeah.
They're at extremely high risk for more resistant infections, and preserving what we have is crucial because you don't want your most vulnerable to be at the highest risk.
Yeah, and everybody knows somebody who's had or has cancer. So we're talking about our loved ones here, who could potentially be needing these medicines. So it's pretty crucial. Just like appropriate use, if you are prescribed one, use the whole thing, because not finishing the course can cause resistance too, right?
Yeah, I mean, not appropriately treating the infection for however long it's supposed to be treated certainly can lead to resistance or treatment failure, really. Right? If something's supposed to be treated for 7 days and we stop it after 3 because we feel better, there's a chance that you relapse or possibly, down the line, maybe you do feel fine for a while, or now you have something resistant. That's the important reason for taking things, I think, as prescribed.
And then for us too, as providers, to not prolong a course that could be short on the other end of things.
Totally agree. That's a big topic. And I think outside of using the most optimal drug, it's treating for the most optimal duration.
Yeah.
And I think they've continued to publish studies on how long we should treat certain conditions, and the more studies that come out, the more likely they are to say, you probably need to treat for 5 days, not 10 days. So I think that is a very, very good point.
Exactly. Don't be afraid to treat for a shorter time.
There's no benefit really for a lot of our common conditions like cellulitis, UTIs, pneumonias to really treat longer than 5 to 7 days for a lot of these conditions. Whereas previously, oftentimes it was 10 days, 14 days. Really, a lot shorter is just as effective, and probably reduces your chance for developing resistance, developing C. diff, having side effects.
Yeah, exactly. Yeah, if you think about some of your antibiotics too, like doxycycline. And that makes you feel pretty sick to the stomach, right?
Yeah.
So,
most people that take doxycycline are probably going to have an upset stomach.
Yeah, right. You're going to feel terrible. And then if it's summertime, forget it. because you're going to get a sunburn if you're out there. You have to avoid being in the sun. It's a very complicated thing, with food, without food. I mean, who needs to do that for longer than they need to, right? Right. So it's better just to be careful, be wary of these things. Is there anything else, like you do this all the time, you're the head of the team here with the antibiotic stewardship. What else do you want to say? Like, this is important, this is our chance to tell people, and I want you to definitely, out of everyone, get your word out.
Yeah, so I think the biggest thing is, like we talked about before, is just we're all on the same team with this, and patients, family, providers, pharmacists, nurses, everybody involved, we really have to work as a team if we want to make great progress combating resistance and keeping the most effective antibiotics, or tools as we call them, effective over time. And that's really the only way I think this is going to happen. Educating patients, understanding when something is likely viral, when something's likely bacterial, is just crucial, because if we keep treating viral infections with antibiotics, we're not going to see that, and we're going to see resistance patterns grow, and we're going to see harder to treat infections. And I think that can't be stated enough. That is the biggest thing. I think it's educating everybody about this topic. We do some stuff in our clinics and primary care. We have, the signage and put things up, but I truly think it's everybody's effort in this that is going to make this possible.
Like we've seen, as a team, as a world, if we do work together, then good things can happen.
Yeah, absolutely.
Yeah, like you said, it's a good point to try to realize, how do you diagnose bacterial versus viral? I mean, people often think, well, my cough is worse. That's mucus in your sinuses, that's mucus in your lungs. If you have a high fever, you're sweating, and you got green junk coming out, and your cough is worse. Okay, maybe you have a bacterial pneumonia, sinusitis, whatever the case, you should get checked out. But if everything is pretty much the same, or you're okay, you don't have a fever, coughs are really irritating things. I mean, those can last for weeks.
Yeah. Yes,
and it happens to the best of us. And there's some viruses, they cause so much inflammation because your body's immune system, it's at war with this virus and all this inflammation, all this mucus. And once the whole war zone is gone, it leaves a mess in your body. And your body's trying to cough out all the junk. I mean, for one little bit of phlegm sitting in there, you're going to hack and hack and hack. One thing I try to push for people, it doesn't matter if they're kids or adults, you have to drink water. If you don't drink enough water when you have a cough, that piece of mucus is just going to sit there being thick and not come out. If you drink water, you're hydrated, things are going to loosen up, you can get rid of it easier. So think about, like, very rarely is a cough mean you've got a bacterial infection. That's not a sign of a bacteria. A lot of sore throats are not a bacteria. Your UTIs, your strep throat, some of your skin infections, those are bacterial. Yeah. And this is me from the outpatient perspective. I mean, inpatient is a whole different animal too.
In inpatient, I think we do see some stuff that we call it asymptomatic bacteria, which is often confused with a UTI.
Yeah.
And just because somebody has something growing in their urine doesn't mean that it's infected.
Right.
And we see that often here, where you have to determine, like, does this patient have symptoms?
Right. I mean, think about it logically. We have bacteria in our body. There's bacteria in urine, there's bacteria in stool, there's bacteria in your gut, there's bacteria in your throat, in your nares. Like, we live with bacteria that are supposed to be there. Yeah,
and that's okay.
Yeah, and it's supposed to be there.
It's
good for you. Yeah, you have all
those... You should not try to get rid of all of it.
Right, bad for you. We all work together. Definitely try to consider, if your provider tells you, or if you are a provider, think about whether these worsening symptoms are due to something else, not necessarily a bacterial infection.
Right.
So let's not misdiagnose and think, or you're going to worry, I have this infection, I've been in the hospital for so long, this is going on, that's going on. It may not be a bacteria. It's something else happening. And so just considering what that means. A lot of stomach bugs, you're actually not supposed to treat a lot of stomach bugs with antibiotics, could make it worse. So let it run its treat the symptoms. Yeah. Drink water there too. Stay hydrated.
Yeah, you're right.
Water is a good cure for a lot of things. So just keeping those things in mind, just like you said, this is a worldwide problem, right?
It's a worldwide problem. Yeah. Absolutely.
People are taking antibiotics wrongly all over the world. Interestingly, if we come outside of our boxes and read something like don't read Facebook, read like the National Geographic, read the CDC website. I know there's a lot of mistrust with the CDC because of COVID, but the CDC was trying to do their best too. They're trying to guide us. They're trying to guide us for this with the information they have. And they're trying to help us too. Like the rules keep changing because the situation keeps changing. Yeah. But their website and National Geographic and World Health Organization talk a lot about these global problems so we can think about the world at large. Yeah. People are traveling all the time. We're all spreading microorganisms to each other all the time. Yep. So we're dealing with the same thing. Yeah. Interestingly, I was reading too, it's kind of sad because there's billions of people in the world. It was kind of like mind-blowing for me to read. Like over 25% of the world's population lacks access to basic sanitation. If you don't have the ability to stay clean and have clean drinking water, you're going to get bacteria, you're going to get infections. Absolutely. And you're going to use antibiotics or you're not going to have access to antibiotics. But if you use them for these infections, that's a lot of use. And the more you use something, the more we run into problems.
Yes, we do. The World Health Organization publishes they call them the threats, the organisms that are threats. And, a lot of the ones that we see here in the United States are on that list. And a lot of it's because of the building resistance to a lot of organisms. It just goes back to doing the best that we can. And maybe all of our efforts can't necessarily stop some of these things from happening, but it certainly can help to slow some of these things from happening. And that's really the biggest thing that we can do as providers, pharmacists, and people working with our patients.
Yeah. Maybe take a look at some of these issues. I mean, this is a separate subtopic, but take a look at some of the issues in the world. It's a tough situation. I mean, just to educate, let's try to read some more and maybe teach our kids about what's happening. I mean, National Geographic has a little magazine for kids too, so it's good to learn and teach and just keep an open mind on how the whole world affects each other and how we all affect each other, and everything you do is affecting everybody else.
Yeah, this is not just a problem here. I mean, it's U.S. Antibiotic Awareness Week, but it's obviously a global issue. Yeah. And the CDC does have great resources on it. They have a lot of patient handouts, patient information. Yeah. Anybody can go and find it. Yeah. It's really excellent information about virus versus bacteria, what to do with some of these viruses, like how to, like you said, water, hydration, right? Yeah, cough medicine, whatever it may be. Yeah. But there's lots of great resources on their website.
A lot of things. CDC.gov.
CDC.gov.
Easy to find. So anything, last words of wisdom you want to wrap up with here?
Going back to just everybody just kind of being on the same page and educating our patients and the community on these topics, I think is just crucial. And just all of us working together, I think is the biggest thing that we can do. Like I said before, I'm very passionate about this topic, and I want to see the patients get the best care possible, as all the providers do as well. And that's really what it comes down to. It's that patient-centered model and focusing on what's going to make them have the best outcome.
It's really trying to take care of people. That's what it comes down to.
That's it.
Right. We're fortunate we have this awareness week and we have stewardship programs with leaders like you. So I'm really happy that you're able to take some of your personal time to sit here with me. So
thank you.
And thank you so much.
I appreciate it. Thanks for having me.